Hello, my friends. Welcome back to my another lecture or a brief talk on severe chest trauma and what are the challenges which are faced by an intensivist. I am your friend, Dr. Shrikant Sahasrabudhe once again, and belated wishes to all of you for the Dashera. For this particular talk, I have decided that I will divide my talk into two, like part 1 and part 2. So today we will discuss the part 1 and the next will be part 2. So let's start, my friends. So what are the challenges? They could be in the form of managing the respiratory instabilities, which can be due to alterations in the respiratory mechanics due to hypercapnia, respiratory failures, and respiratory acidosis. It can be due to shunt, and shunt is predominantly can be due to pulmonary contusion, which can be divided as mild, moderate, and severe, as you can see on the screen. Hemorrhages, ARDS, edema, which is responsible for hypoxia. It can be also due to hypoxia, and hypoxia is predominantly due to pneumothorax, hemothorax, volume resuscitation, and inflammation. It can also be due to massive transfusions where the patient may need more than 10 units of PCV, and 15% of the patients can have TRALI, and about the same percentage can have TACO, that is transfusion associated cardiac overload. High AIS, that is abbreviated injury score, more than 4, and injury severity score of more than 30. Elderly patient, severe lung contusion, which can have high mortality. So the one group of patient you're looking at is to manage the respiratory instabilities, which we just saw, the causes and the conditions. The second category of patients who can have hemodynamic instabilities, which can have cardiac tamponade, and it can actually give rise to a circulatory failure. The patient can have hemorrhage and they can have hemorrhagic shock, and the patient is immobilized, which has a risk factor for DVT and PE. And my friends, this is a suggested reading, so I've taken a few of the references from the World Journal of Emergency Surgery 2020 and Journal of Emergency Critical Care Medicine 2018. So there can be tracheobronchial injuries, and this is also can be abbreviated as TBI, but it is different from the traumatic brain injury, and this is mainly related with the airway. So how will you know that this patient may have potential tracheobronchial injuries? So someone with mediastinal air in isolation without associated pneumothorax or lung laceration. There is no evidence of any aerated tract from a soft tissue injury, neither from infradiaphragmatic source. So this should pose the potential possibility of tracheobronchial injury or airway injury. It can also have respiratory distress, which can be made worse with positive pressure ventilation. There can be a continued and sustained air leak on well placed chest tube. There can be severe subcutaneous emphysema, which can be seen in about 35 to 85% of the cases. And of course, the patient can have hemoptysis. So, all these clinical findings at the bedside should raise the suspicion of tracheobronchial injuries in a patient of severe chest trauma. And how to go about it is in few patients, we may go ahead with bronchoscopy and, of course, definitive surgical repair. Now, what about breathing, which can be predominantly due to disruption of bony thorax and pulmonary injury? So, the patients with rib fractures, which are seen in about 10 to 20% of the patients, can actually have the the side effects or the complications in the form of pulmonary contusions, hemorrhages, which will eventually give rise to respiratory failure. The rib fractures can be displaced, multiple, bilateral, and comminuted. There could be elderly patients with comorbidities, and these category of patients would have loss of respiratory mechanics. There can be a significant pain, and mind you, pain is an extremely important clinical finding which we need to actually mitigate on priority basis, and analgesia should be very optimal. So, severe pain can lead to chest wall splinting and decrease in the inspiratory capacity. There can be lung injury, and of course, it can lead to ARDS. There could be additional risk fractures where the mortality can go up by about 20%, and the risk of pneumonia can go high, up to about 27%. And what are the poor prognostic markers? Are the patients with saturations of less than 92% on room air, or the patients with tidal volume of less than 1.4 liters. Now, as I said, the pain, which is an integral part of the, the trauma management, can pose the problems of sputum retention. And these problems are complicated by collapse, impaired gas exchanges. There could be increase in the work of breathing. Patient can get infections in the form of lower respiratory tract or pneumonias, aspiration pneumonias, and it is especially true for patients who are smokers and underlying lung diseases. Now, the solutions is of course analgesia. As I said, analgesia, and optimal analgesia is the answer to mitigate this problem of pain. The patient can be asked to do aggressive incentive spirometry or chest physiotherapy, humidifications, suctionings, and the position change. As I said, analgesia, which forms a cornerstone for the pain, and this is a paper which is from the Journal of Trauma in 2005, and as it has clearly and explicitly mentioned the analgesia in the form of intravenous morphine or fentanyl by frequent small boluses or continuous infusion, thoracic epidural infusion of combined opioid and local anesthetic agent like fentanyl plus bupivacaine. We can actually also contemplate the intercostal nerve block with either a single bolus of 20 ml of 0.5% bupivacaine, and paravertebral blocks which can also be kind of performed, NSAIDs which can be delivered to the patient, and of course paracetamol, which is the safest NSAID which needs to be regularly given for the patients, except the patients with hepatic dysfunction. So by and large, I think in my slide today, in my talk today, this slide is extremely important. Now, what could be the immediate management of chest trauma? Of course, we would go ahead with intercostal drain in patients with pneumothorax and hemothorax. We would go ahead with urgent thoracotomy in patients with pericardial tamponade, diaphragmatic rupture, and massive hemothorax. And the indications for emergency thoracotomy would be witnessed loss of vital signs after the penetrating trauma. What are the indications for intubation and positive pressure is of course airway compromise, gross hypoventilation mainly due to pain, or hypoxemia which is not attributable to pneumothorax, and severe head injury. So when you have these three conditions, don't wait for anything else. Don't even think of non-invasive ventilation in these patients. Straight away you need to go ahead and intubate these patients. So there could be a three-prong approach as far as the treatment of blunt chest trauma is concerned. So the first is the surgical fixation either of the ribs for the flail chest, and we should actually we can discuss it in my the next part which I just said, the part 2. There could be analgesia which we just now discussed, and the clinical pathways. So this is a three prong approach which anyone would contemplate, when we are faced with blunt chest trauma patients. So it is just a quiz to you, and I'm going to kind of just hold on with this slide for maybe couple of seconds for you to answer this question, and you can put your answer in the comment box so that I would know that how many of you have really responded. So, what are the causes of cardiovascular collapse on induction of anesthesia and positive pressure ventilation in chest injured patients? You can answer that. And I'm going to take off this block within some time for you to know what are the correct answers. You can please type your answers in the comment box. It's just kind of a self assessment. So these are the answers: excessive anesthetic agent, hypovolemia, esophageal intubation with hypoxia, tension pneumothorax, pericardial tamponade. Anaphylaxis is extremely important, especially for an anesthetic agent, systemic air embolism, and severe blunt cardiac injury. So these are the predominant causes of cardiovascular collapse, and one should not forget this. Now, similar lines, I have another slide with question, and you can please type your answers in the comment box. What are the causes of pneumothorax, subcutaneous emphysema, and or pneumomediastinum in the patients of blunt severe chest trauma? And I will again wait for some time for you to answer this. So I don't want this as a monologue. I want you all to interact in this fashion where you can type your answers. So let us see the answer. So the reasons or the causes are lung puncture, tracheobronchial injury, esophageal injury, facial or pharyngeal injury, and abdominal or retroperitoneal injury. These are all the causes of pneumothorax, subcutaneous emphysema, and pneumomediastinum. As I said, I would like to stop here, and I would say that the part 1 is over here, and in part 2, in the next video, which will be the continuation of this topic, we would cover flail chest, its management, presentation, and so on and so forth. I'm sure, guys, I think you all like the way I present, and I would urge you all to subscribe my channel, share, and put your comments into the comment box. Take care. Thank you very much.